Hello, everybody. Welcome to National Accessibility Week. Today, reachAbility is bringing a workshop on the subject of the pandemic and how it is affecting people in the disability community. So every day this week, we're going to be talking about different subjects and diving deep into a lot of really important accessibility issues with a bunch of excellent people from our community and from all across Canada. So I would really recommend that you go to the reachability.org website and check out the schedule and sign up for as many things as you can, because it's a really interesting time to spend some time learning and exploring these topics. Before we get started, I would like to begin by acknowledging that we are in Mi'kmaq, the unceded and ancestral territory of the Mi'kmaq people, and we are honored to work and live in this territory. So just to get started, I'll introduce myself. I am Mara, the pre-employment support navigator from reachAbility, and I'm also the registered social worker on staff. And today I'm going to be joined by some people on the front lines of the pandemic and healthcare, and talking about how they personally and professionally are seeing the pandemic and the response affecting people with disabilities. And I think this is a great opportunity for us to explore what we're seeing, but also what we dream of, what we hope for our response, and what we think might become possible from what we learn at this time. So I'm going to start to welcome my panelists. First off, I would like to welcome Dr. Maria Patriquin. Dr. Patriquin is a family doctor in Halifax who is passionate about system change. And hi, Dr. Patriquin. Hello. And she founded and runs the excellent Living Well Integrative Health Center, which delivers an innovative form of collaborative care here in Halifax that we're lucky to have. And I always see her in the context of her passion about system change and how we can do better to serve our clients and our community. And so I wanted to invite her to be part of this discussion. Hi, Maria.
Thank you. Hi.
And next up, I'm going to invite Andrew Jantzen. Andrew is the Atlantic Regional Coordinator for Tetra Society, and he also is a person who lives with a rare genetic condition called Ehlers-Danlos. Hi, Andrew.
Hi.
And Andrew writes a riveting blog called Tales of a Home Care Castaway that is both really well written and really important, and I would recommend people to check it out. Andrew started this blog because of the conditions of the pandemic. Is that true, Andrew?
Mm-hmm. Yes.
Yeah. So it's very timely and I find really moving and important. So check it out. And next, I'm going to invite Erin Iles. Erin is an occupational therapist for Mobile Outreach Street Health and also works for Dartmouth Connections. And Erin works with people who are experiencing homelessness and mental illness and has insight on how that is part of this experience of the pandemic as well, and what we can learn from our response. And I'm looking forward to hearing all about that. Hi, Erin.
Hi, thanks for having me.
Yeah, welcome. And we also have our last panelist is coming on. Her name is Brandis Greene. Brandis is a continuing care assistant at CBI Health. Hi, Brandis.
Hi.
She is currently training as a counselor, bonus for her clients who often are mostly seeking care from her and could use some other services perhaps. So we'll be talking about that for sure. And Brandis has been serving our community in home health for 12 years, and we're really proud to have her here with us. Hi, Brandis.
Thank you. Hi.
So as a little check-in question, welcome everyone. Thank you for coming on. I'd like to hear from each of you in turn about who you work with in your professional capacity and how your work has changed during this pandemic. Like what sort of structurally has changed, or what you're seeing that's different in a kind of basic way. What's like the main thing that comes to mind when I mention that? And I'll start with Dr. Patriquin.
Sure. So I guess I have multiple roles in my center other than running the center itself, as both dual roles as a family physician and then also doing psychotherapy. I've developed lots of group work is predominantly how I work with people, but also one-on-one, and developed a number of programs that people can access, like they can overcome the barriers of accessing those without having private insurance. So those are programs that are often utilized by people with disabilities as well too. I have a full, I guess I provide what they call full spectrum care. So that means like babies to geriatrics. And I have a really multicultural and diverse patient practice, which is really lovely for me. I guess most of my care is now not in person. That's the biggest change. And so it's, as they call it, virtual, although I don't really like that word necessarily. I think it's remote is more appropriate because it's still care. And I guess that's problematic because not everybody can access care. There's an assumption based on accessibility to the technology itself, which people don't have. And I guess I feel like a lot of the work I do really necessitates a human connection. And although technology advances and it's super helpful and obviously in many ways enables access, there's nuanced parts of it that I find make it difficult to do the kind of work that I normally do as well too. The biggest challenge, I guess, from a patient care safety perspective would be, I guess, what I'd say, because overall there's just less resources for people. So like there's less home care, if any home care at all for a lot of patients. I had several calls today around that you can't get test results done. You can't get tests done that might be necessary. So there's like this feeling like it's harder to keep people safe too, and just to ensure a baseline amount of care. And I think what's really important about that is that although there are less resources, so they're not accessible to everyone, that doesn't affect everyone equally. It affects people who do have complexity to them, to their care or to their lives, including disabilities, making it much harder. And it affects them, I guess, in a disproportionate way, I would say. Yeah.
Thank you, Maria. I would love to check in with Erin about this question. Hi, Erin.
Hi. So I guess to give some context in what I do, I should explain what occupational therapy is. So in kind of a quick speed dating, I guess, summary of OT, OT support people in doing what they want or need to do. So needs might center around what we call in healthcare, like toileting, getting dressed, getting up in the morning, looking after yourself. All those things we kind of call activities of daily living. And then supporting people in what they want to do. So it includes those activities that sort of give meaning and engagement and enjoyment to people. So I work at Connections Dartmouth, which is a community mental health program. So there have been, and I work at MOSH as well. So there's been changes in both workplaces I go to. A lot to do with reduced programming. So to give you some background in Connections Dartmouth, it's a community mental health program that provides services to individuals living with mental illness who also have substantial functional challenges. So pre-COVID, we had lots of programs that would occur at Connections Dartmouth, like weekly lunches, drop-ins, coffee, mindfulness, recreation, all those things that we know kind of supports mental health by providing opportunities for engagement and socialization. So we've had to stop those during COVID, and we're really kind of limiting to bare bone essential services. So there are still some clients coming in if they need to get antipsychotic injections, for example. But mostly our one-on-one appointments have moved to telehealth. And at MOSH, similar to Connections, we had to shut down some of the services that happen in groups. So we had to shut down our walk-in clinic, and most of our appointments, if we can, are occurring over the phone. But due to access issues, a lot of our clients don't have access to phones. So largely, we still have our outreach happening at shelters and on the streets just because there are still essential services. The difference is that our healthcare workers are dressed in PPE and really trying to follow and teach those social distancing protocols. And then, so a big barrier I'm seeing, especially in my work, the contrast between Connections and MOSH is Connections. We were lucky to have funding to provide our clients with phones so they could still make their phone appointments, whereas MOSH, there's lack of resources. So those, I'd say, those are the main sort of changes I've seen. And another change that's been interesting is a lot of the shelters have switched to hotel or pop-up models just to allow for social distancing. So there's new sites that homeless individuals are staying at, so different spaces for outreach, which has had interesting implications for the people I work with.
Thank you, Erin. That was really comprehensive and helpful. Thank you. Andrew, I know that you work in a different capacity. You don't work as a healthcare provider, but you do serve people in the disability community through Tetra. And I wanted to check in with sort of how that has changed, but also how your experience of relating to care providers has changed, if you'd be willing to check in with that.
Yes, for sure. It is interesting for me having those two different things, both right now in the same place, like in my home. I do both of those things, so it's all mashed together in some ways. I work with Tetra. Like Tetra, we work building custom assistive devices for people, and that involves people with disabilities and our wide volunteer base, which includes people with disabilities, but is a lot of like a wide array of people with tech and trade skills, people in the health professions. So really, we work with anyone in that sense, but it all centers around that person-to-person connection. So a custom assistive device, you really often need to be there to interact with whatever barrier you're facing to be able to create a problem solve around that. So we've had to switch from doing that in person to doing that virtually. And some projects that works really well for, and some it doesn't. So there's a little bit of experimenting and trying new things. And luckily we do have chapters across Canada and some internationally. So it means there's actually a lot of people doing this creative problem solving. So we've had some good examples of how to go about doing that from BC in particular. We've been trying to adapt those models. So that's been a big change. For me personally, the biggest change, I guess home care is one of the biggest changes. And it's been really helpful to have these other people actually talk about OT and assistive types of activities, like activities of daily living, because then I don't have to explain that. So thank you. But for me, like an assistive device sometimes is helpful, but there's often things that a device can't do. So then you need human support to be able to accomplish basic tasks and also fun tasks. So I guess what I see often happening in the public eye is that during the pandemic, people are being encouraged to do self-care or stay home and do some baking and some cooking, different activities like this. And I listen to that and think, well, I can't do anything on there without another person. So that's a huge barrier to just being able to adapt to this. Like, I mean, my day hasn't changed a lot in terms of isolation because I was in some ways before, but having it be that the services that help me do the most basic things are being reduced to the most basic has a huge impact on anyone who receives these services. So myself, I'm rated in priority higher than a lot of other people. I don't have a lot of other ways to meet those needs, and I live on my own and have some barriers like that. Don't have a family here. So I actually right now I'm still getting some care, and I know a lot of people are not. Things have just been like, I still have cancellations that are happening frequently. And even when I do get workers, it's a lot of new people because either they're like all the staff are off right now and they just fill them with who they have. But yeah, the biggest change is essentially that I was having to manage my own care a little bit before in my day-to-day, but now I spend most of my time just trying to manage my own care. So it becomes more than a second job. It kind of takes over your life in a way. When I'd really like to do some of those relaxing things and to be able to, de-stress, because during a pandemic, there's a lot of that going on. And to be able to take care of our basic needs, we need our home care services. We need our support people, personal support workers. So yeah, it's one of the biggest.
Thank you, Andrew. Yeah, I listened to an informative FAQ with the World Health Organization about disability and the pandemic really early on. And the person, very helpful, well-meaning person who was giving advice to the disability community was saying, just make sure if you are a person who uses home care that you have a backup plan to your backup plan. And I was just wanting to shake the screen because I know the most resourceful and organized and hardworking people with disabilities who cannot under any circumstances find multiple layers of care because one layer of care is already taking a ton of time and work to establish. And there just aren't these services that you can call on to back up your backups. So it's really intense. And that brings us to Brandis. Brandis, how are you finding this is affecting the people you serve in your practice?
It's definitely changed everything. Andrew really highlighted some main points there. So of course, in home healthcare, we work with many different families, many different people with diversity in culture, with issues with physical health, with mental health issues. It's been really intense, to be honest, quite exhausting, I feel like, for everybody. We've had a lot of changes in protocol, of course, with PPE and screening when we're going into homes. The increase in demand for home care services has definitely been very high right now. We're dealing with a lot of staffing issues and that type of thing. It's just been, it's definitely been a challenge. I feel like we're not able to serve the community right now like we need to. And our clients are really missing out on a lot of care that they do need. Their visits have been shortened up during the daytime, which is causing a lot of issues too. Just trying to kind of get everybody in our day taken care of. There's a lot of moving parts. And a lot of the people are struggling right now at home, definitely. And not just the people who are getting the care, but the caregivers also that live with them. The overload is really being put on their backs as well.
Thank you.
So, yeah.
Yeah. So I find it really helpful to hear these stories. And as I was able to talk to each of you before this, I heard different stories from you about kind of particular kinds of cases that you're seeing and what people are going through that I found really eye-opening to getting a sense of the diversity of ways in which people with disabilities are being affected by this pandemic and our response to it. Sometimes, you have your kind of key things you're already tuned into that you're thinking about. Like for me, that's mental health. I'm always thinking about the secondary pandemic of how this is affecting people with mental health, and I want to hear more about that. But then there are people that are just not on my radar at all in terms of their needs because I don't have enough daily exposure. And then I hear a story and I'm like, oh my goodness, I'm like completely shook thinking about how this is affecting a group of people that, I hadn't had enough awareness of. So those stories really helped me. And so I thought I would ask you if you had a case study, or just an example from some kind of care interaction that you've seen around you in terms of how people are being affected.
Absolutely. So there's a couple. Yeah, I have somebody who's palliative right now. I think it's a beautiful thing for people to be able to be palliative and be at home with their families. However, there's a level of support that needs to be given in order for these people to be taken care of properly in the home during their last days of life. And that's been extremely hard to meet. I went to a family a couple of weeks ago, and they're literally getting 2 hours a week is all they can get right now for home care to come in and help take care of this individual, which is leaving the partner to just do absolutely everything and is exhausted. So it's wonderful when we can keep people out of hospitals and out of long-term care facilities, but we can't do that properly if we don't have the support that we need to do it.
Yeah, absolutely. That's a great example. Thank you. Erin, did you have an example that you wanted to give of?
Yeah, so an interesting thing I've noticed working on the MOSH side. So MOSH, we work with people who are homeless or at risk for homelessness. So the people we serve, it's quite broad because there's many different factors leading to homelessness. But since the shelters moved to this hotel model, something that stuck out to me was about sort of universal designs and shelters and the relationship between mobility and homelessness. So prior to COVID, when I was working with someone who had a physical disability and they were homeless, if you think of the shelters around Halifax, very few are accessible, and not and the ones that are not very accessible to a lot of people, they're minimally accessible. So if you were lucky and you had a disability, they'd fund you to go to a hotel to live until you found more housing. But an issue that arises with that is you're kind of siloed from the shelter staff because you're at this hotel that's separate from the shelter, and they have housing support staffs. They have other clients there who you can interact with. So I found before, when an individual I was working with who was homeless with a physical disability, they were really kind of siloed and isolated. And now that they've moved a bunch of the shelters to hotels, individuals I work with mobility concerns or issues are able to kind of live with other residents who are also homeless. So it's been kind of interesting because it really made me think of the importance of universal design in shelters and homelessness and the relationship between homelessness and physical disability. So it was kind of seeing clients I've worked with. There's one particular client coming to mind who, now that she's in shelter with one of the women's shelters, she's actually getting more attention from the staff because she's able to see them on a day-to-day basis. They're able to, she's able to interact with other clients. So she gets that social aspect. So I think it's really brought to light some of the cracks in our systems. The fact that our shelters aren't fully accessible, I think, is a huge problem.
Yeah, that's really interesting. And I think it's such a good example of how we can, like, we knew that our shelters weren't very accessible, but then you see this other model in play because of this emergency. And it really brings to mind, like, oh, there's actually, we know how to fix this.
Yeah, and she's actually been able to get limited home care, go to the hotel too, which would be more difficult in a shelter situation. So it's been pretty cool. And for OTs, we do a lot of assistive equipment and environmental adaptation. So hotels have accessible units in them. So it's been quite, it's just been an easier transition for supporting people with different needs.
Thank you. Maria, did you have any examples or stories that you wanted to give?
Tons.
Yeah, just a couple.
I mean, I think what's kind of interesting to me, and Mara, you and I having worked together before, is that that I really see people as the faceted way that they are, and health in a very expansive, holistic way. And I think the interesting thing about care during COVID is that people and things are reduced to problems, and it's not how I conceptualize care or people's lives. And so I find that challenging. And it just sort of came to me just now that that's a lot of how I even conceptualize how I could answer these questions here today. And normally, everything I run is very heterogeneous. I don't want a homogeneous group population, even when I do my counseling and my mindfulness sessions. It's a really diverse group, age, ethnicity, and every abilities and disabilities, what have you. And I guess how I thought to answer this is I would sort of separate things, even though I don't conceptualize health as being separate as physical or emotional or intellectual or what have you. But for the purposes of examples, that's sort of how I thought of things. So example with the wheelchair, again, we've talked about home care supports not being existent, but certain things like accessibility to food. And in some ways, some of that, because it's very obvious that this person has limitations, there have been people that have been very helpful that way. But even simple things like wearing a glove with a wheel to move a wheel is not possible. So there's like an increased risk exposure just because the hands, we're all saying hand washing, but it's not even possible for him to prepare, this one particular person, propel his wheelchair with his hands. Medications started being dispensed on a monthly basis, which means that people who need more meds tend to have more complexity and more complex health problems. And then all of a sudden they have to go every month to get their medications, which increases their exposure risk. Patients of mine who are blind feel more tension and stress because it's sort of palpable when you go out, right? And then they become more fearful about who can I trust to ask to cross the street. And when they've accessed, let's say, for example, some people are accessing, say, Hope Cottage very regularly, a lot of my patients, they are no longer giving a full meal, which actually they were very, very reliant on doing. It's like a sandwich, and it's actually not meeting their nutritional needs because it's been so reduced, understandably, to try to keep it as a public health measure. For those with intellectual challenges, I found that really, really difficult because as a healthcare provider, I'm confused by the information and I read it multiple times a day. And so I can't even possibly, it's very difficult to comprehend the information, the guidelines, the rules, to keep up to date with them. And I think we assume a certain amount of comprehension and also literacy, right? My patients who have intellectual disabilities have had more emergency room visits, which does also increase their exposure risk. they've not understood things, so they've been quicker to go back. So I think that's been a really concerning place. That's a big gap that I've seen in the system in terms of being able to provide that. But one that could also be easily remediated, which I know we're not on that part of our questioning yet, but through communication, right? Like simply through communication, which for people who have intellectual disabilities is challenged. So this really requires people to step up who are in their circle of care. And of course, doing mental health care, which again, I don't conceptualize health as being separate, physical from mental. And I think, there's a beautiful opportunity in all this, in that not everyone will get COVID, but absolutely everybody's mental health is being challenged right now. So, and I think but in saying that, it's similar to, as I said before, is that around the limited resources, it doesn't affect everybody in the same way. And so that people who have established mental illness are affected more by the particular restrictions in, resources, but as well as access to them, but also just by the actual events, and not just COVID, but the other events that out in the world at this time. And so I think their needs are higher. There is a lot of trauma, and trauma is not something that's particularly recognized in mental health care pervasively, and it really is a big issue. And in a circumstance or under pandemic, when everyone feels under threat, that's one particular type of mental health challenge that's particularly challenged by not being in a place of feeling in control or having increased access to care. Then when you access care and it's largely misunderstood, it's really challenging for people too. That would be sort of like how I've kind of categorized the variety. And of course, because I do family medicine, it's like there is a big variety of challenges for people who are facing certain disabilities.
Right.
Yeah.
And across the spectrum of age too, like anxious
absolutely.
children not understanding things, and
totally,
just older adults who are disoriented, and
single moms alone with children who have autism that have no respite, they have no supports. It's super challenging. Yeah.
And I always also want to be aware of the kind of multi-layered challenges that people are experiencing in terms of their positionality. Like definitely people in our community who are African Nova Scotian are going through their own really intense time right now. And we see how care is, definitely not equal in terms of race, and all around us, people really struggle with accessing systems that are so important right now. And also we're seeing that for sure with low income people. Like what I keep coming back to thinking about, just like people not having phones. It's like everything is like, don't worry, you can call. Don't leave your house, just call. Like, how are you getting this information if you don't have a phone? And how are you supposed to communicate with any services at all? It's very intense. And
I just wanted to give one example, because you were talking about trauma in the community right now, and I just find that right after the mass shooting, of course, we're going into people's homes all the time, and often we're the only ones they're seeing right now. They can't get out. They can't. All the social activities in the community are not happening right now, or they just can't get out because of their disabilities in the first place. And just to give an example of a quick story, I went in one morning, just a regular day of work, of course. And the first person I was at, who is isolated, of course, from her family, she can't see her family, she can't get out. It was a family member of one of the victims in the shooting. So, not only is she struggling with the COVID things happening and being in isolation in the first place, now she's grieving as well on her own, which is devastating for people. And of course, we're to keep our distance as much as we can, being in home health care. But of course, I did hug her. I couldn't leave her crying in front of me, as I was the only one she was able to see that day. And that's how it's been a lot of isolation, a lot of fear. And these people are even more alone than they ever have been. And they normally are quite alone in the first place. So I just wanted to add that, because you were touching on that. And it's really added to the anxiety in the community, I find. So
thank you, Brandis. That's such an important example, and also another layer of where people are at in terms of how this is landing for them. And I also, when you were talking about that, I'm also struck by thinking about the one thing we also haven't mentioned is that there's obviously a very elevated risk of people experiencing psychosis and other mental health emergencies that they have maybe never experienced before, or even for a very long time, their mental health has been pretty managed and steady. And then in this moment, it's like a lot of people are experiencing new crises, and it's hard to even recognize a person who's on that tipping point if they're alone in their house and they don't have anyone to check on them. So there's also an opportunity for people to get much further along into a crisis before there's any kind of intervention. Not that our system was particularly responsive always before. Now it's particularly drastic, I'm finding. Yeah, it's really something.
Yeah.
Andrew, I wanted to check in with you about this question in terms of what you're seeing around you in your disability community, in terms of examples of how people are being affected that maybe haven't come up yet. Do you have any thoughts on that?
I do have some thoughts on that. And I'll probably share mostly from my experience because that's what I know best. But I know that like the ways that I see it come together for myself are very familiar in other stories that I see as well. And it's when, especially when chronic health and chronic illness comes together with the way that our home care and our healthcare system have changed in this pandemic. And I did want to touch on a few things that we mentioned just before about like the system before this was not working exceptionally well either. So a lot of the things that are happening are, as other people have already said, it's when things have, the gaps and the issues have amplified. So things have changed in some ways, but often it's just they've made things worse for people who already were experiencing challenges to begin with. So yeah, in terms of like home care, since I posted my blog, I've had a lot of individuals reach out to me and either share their own experience or people in their family and friends and community too. So it's a familiar thing. And a lot of us were experiencing like inconsistent and not quite there care beforehand. And that's not the workers' fault. That is the way that the system is functioning because of lack of funding and the structure and those kinds of things. It's that there's never enough time to get things done, even when you had the care. There are lots of barriers to it. And then add on top of that our new way of being, and that changes things. So the backup plan that we talked about to begin with, before this was happening, we're expected to have a backup plan at any given time. That's the way that you're kind of welcomed to the system, is that the home care system is set up to be a supplement to your existing care support system. That's how it's framed. So for a lot of people, that's not how that service is used. Like for myself, I don't have family out here. The home care system is what provides a lot of that care. And then I can find some people like some of the time if I need to, but they're not people who live with me, and they're not like, I don't have a regular like wide support system like that. And that's very typical. And that's something I don't think that people necessarily realize, is that the home care system is the support system. So like other people are talking about when, this falling on a partner, and that's very real. And that happens to a lot of folks. And then when people don't have a partner or family, it falls on no one. So I've spoken to other people who've experienced the same things as me, where we've gone not just days, but often weeks without having a proper bath. Or you've gone like days with just wearing the same clothes because that's what you're working with, or just spending for like the snacks that somebody left out for you days ago, not getting water. And I think that like we see a lot of in the media, they're talking about what's happening in long-term care facilities. And there are similar situations happening to people in community. We're just not all in the same place. So it's harder to see in some ways. Like a specific example from my experience where this all kind of came together is that like I use a catheter. That's part of something that I need to manage my health. So that needs regular care. And if it doesn't get regular care, it will get infected. And I've had to go to the hospital numerous times in this pandemic because I had numerous infections that lasted all of the pandemic, basically because we didn't have enough time to take a proper bath. We weren't I wasn't getting that I wasn't being bathed and that kind of thing, which led to that. And then I wasn't able to see my regular doctors in person so that they could see what was going on. so it wasn't caught. And it got to the point where I had a severe, like, full body infection because of how all these things just came together in a perfect storm. And that perfect storm is that's just what's happening for a lot of people where we're managing chronic health, where, yeah, maybe you don't get your medication when you need it because of those restrictions. And that snowballs into something that sends you to emerge and turns into something that now you're required to be there. But it's like, it's kind of the way that we set it up to be, is that you access the healthcare system right now when you have an emergency, but not as much if it's not. So it's kind of done by design in a way. Yeah, so like, I guess that's a specific example of how that came together for myself.
That was a really helpful example, Andrew. Thank you for sharing that. I definitely am struck by the quality of when you design a system, and for good reasons. Like, we don't want a lot of people at the hospital who could maybe wait a month, because right now it'd be good to keep people out of the hospital. And we certainly don't want you, who's extra high risk, to have to go to the hospital a bunch of times.
Yeah.
But then when you set up a situation where you need an emergency to get care, then you're going to have an emergency at some point because you're not getting any care, right? And so it's like very tricky to figure out, like, what are the long-term, I'm so concerned about the long-term implications for people who have put off tests, who are putting off maintenance. I have people within my practice who have chronic pain, who access regular physiotherapy and other recreation in order to manage pain, and their pain is off the charts, and it's going to affect them for years and maybe for the rest of their lives because they needed to keep on top of this, and now they're falling back, and they're going to end up in rehab facilities and things like that. So that is such a reality that is not in the math in any kind of major way, from what I can imagine. It seems like that's not the thing that is being prioritized from what I'm
also experiencing that long-term side of it in terms of my wheelchair and some of my, like, my braces, and like, these are all splints on my hands and braces, and I'm supposed to have one on my wrist that will allow me to use my wrist, but I need a lot more support with home care and that kind of thing because I don't have the devices that I need that are still in the hospital system, but we can't set those up until the pandemic's done. So my wheelchair hasn't been adjusted since it was damaged in December, and it's currently pinching a nerve in my neck, which is causing nerve issues in my arms and severe pain. So like, these things, once they go on for a certain amount of time, they become chronic, and they're not going to go as easily. And you can access some physio through a video conferencing, but especially if it's a new developing thing, that's very hard to do an assessment of that by distance when it's nerves, and you can't just see that. You have to actually interact. So the long-term part of that is really significant too.
Yeah, thank you, Andrew. So I'm going to go on to the next question that we were going to discuss, which is really about how our practices have changed in terms of our daily life. And anyone who has anything they want to share, I'm just going to let people kind of pop in if they have anything. And I'm thinking about, in some ways, how we have adapted to the changes in terms of how we deliver care, or how we have adapted in terms of how we function in our lives. And if any of that might want to stick around. Like, if we have any ways in which we've changed the way we practice that might feel like it might be helpful, or adaptations that we see around us that we think would be helpful to continue. Like, for example, I can give an example from my practice as a social worker. Usually we offer workshops at reachAbility in person, which is so valuable. And it's a huge part of what we do, is bring people all together into the same boat in some sense of feeling connected and not isolated. And then they access, these services, and that has a huge mental health impact. But then people who can't get there, people who are home and for whatever reason, because of caring for young children, or because of the distance, or because of their mental health, are not feeling like they can come in, they aren't usually accessing our workshops. And now we're offering workshops over Zoom and over just like for the public on Facebook, and we can reach people that we weren't reaching. So I hope that, we have the intention of finding ways to continue to offer remote services when we come back and are able to offer them in person. That's really, for me, that feels like a learning curve that's been really good for us to recognize how we can serve people we weren't serving before. Does anyone else have an example in that way? Erin, maybe?
Well, I think just building on what you said, I think the fact that a lot of work has gone online and some jobs have managed to be successful online with people working from home, actually opened some doors for people living with disabilities. It's showing that work from home is possible in a lot of different ways, and that could kind of open up some employment opportunities for people who might have barriers to getting out into the community. And in my practice, I think this whole pandemic is just really showing what a lifeline technology and has been for accessing healthcare. I mean, personally, I was able to make a doctor's appointment online and then call the next week and have that appointment happen. But for that to go through, I needed my wireless and I needed a cell phone. So through my practice, I've really been trying to connect people to those technologies. And I think it's something I will continue to do because I think the pandemic is just showing the importance of having technology these days. It's almost become like a basic need in a way. Like healthcare in a lot of forms is turned to telehealth or over the phone appointments. So I just think that supporting people and accessing technology is something I'm going to try to continue to practice.
Yeah. We are actually doing a panel this week on the subject of internet as a human right or internet as a basic need. And that's really come up for us in a big way in terms of health disparities. Right now, it's really more noticeable than ever, but I think it's always true. Like booking a doctor's appointment if you don't have a computer and wireless is pretty hard.
We're seeing a lot of that, of course, in home health. We do work with people of all ages, of course, with all sorts of disabilities. But, you know, our elderly population, they just don't access technology like we do. The younger generation. So it's definitely been a challenge for them. So although it is really good for probably a group of individuals for sure that can access more technology, it's definitely still a barrier for our elderly population. Yeah.
Anyone else have any other examples of like adaptations in the way they're practicing or the way they're interacting with healthcare?
I mean, I think that we know that we need to work better together as a community of healthcare providers. And that everybody needs a larger circle of care. So I'll always say that if it's like me and a patient, that's not a circle, that's a straight line. And if it's three people, then that's a triangle. We really need a circle. And if you think about that, I've worked it out that you need 6 people, including yourself, right? And so if we envision that, and that's what everybody really needs to be supported in living their best life, we need to start really valuing the existing resources that we have, like whether it's physio, like you were saying, Andrew. You know, this antiquated term of allied health providers is just, it's got to go. We all have to be allies. And really this kind of collaboration and using existing resources in that way is critical and important. And all of that can really be enabled by, you know, the restructuring of how we distribute resources, because I think there's enough money in the system. I think it is about allocation. And I think we don't pay enough attention to preventative care. So you gave a perfect example, Andrew, as well. Like, you know, if you'd had like access to, you know, a standing requisition and ability to get a urine culture, that could have been prevented, right? From you having a much worse, you know, course of illness. And so I think, you know, there's so many opportunities that we know if we can predict things, we can prevent them. And it really requires far more working together and sort of breaking down these hierarchies that are existence and really antiquated. And the key to that really is, oh, sorry, that's my dog. The kids didn't come in, but the therapy dog did. So I think everybody needs a dog. The dog needs to be one of those 6 points in the circle. Anyway, sorry about that, but I didn't predict that. But, you know, communication is key. And I think, you know, one thing for me as someone who advocates and does policy and all kinds of work around collaborative care is I think what's really important, what we're talking a lot about today is just, you know, understanding lived experience as an incredibly valid source of knowledge and as important as science and research, right? So we need to really have that. And we really need to have like what's called like a journey map. Like, tell me what it's like, you know, to get from here to there or to get that. And any time. And if we understand that, then we understand how many more barriers there are for people accessing care. And then we could start to address them so that they're really person-centered. and they're really helping people. But fundamentally, at the basis of all healthy change has to be more communication.
Yeah, I have to agree. I'm finding, I'd be lying if I said that I didn't find things a struggle right now, going into people's homes and working with them one-on-one. I'm finding, a lot of people are sitting around watching the news at home, which probably isn't the best thing. So, we go in and they just bombard me with questions about, PPE, about anxiety, about depression. I'm seeing a lot of depression right now. Just isolation at its finest. It's really, really highlighted. And I totally agree with you that we really need to communicate more, I feel like, as a healthcare team, and really try to provide to people in the community, because there's a lot of people feeling extremely alone right now, and not really knowing where to turn or what to do for help. Yeah.
And there's so many people who want to help too. So, I think that's the amazing thing. Yeah. And I always had this idea, but they're sort of like liability issues. But I decided with my teen group, actually hell with that. And I had them come in and help me clean an elderly patient's room in a nursing home. So that's what their task was, helping me before the pandemic. And it was just unbelievable to me how much, if we kind of drop too many nuances around liability, there's a lot of people who just want to contribute in a good way. And it benefits everyone, the recipient as well as the person giving. And I think we can mobilize people that way. And that's more how we live in community too, not just talking about expertise in health services and the like, And absolutely. I think it would be negligent if we didn't mention like the determinants of health. Like people not having food has been a serious issue during this. And like, that's unacceptable. Like, yeah. I mean, the little bookcases, libraries, they should be turned into little food banks. Like people have had big issues with food, and
that's people who can even get out. Like again, a lot of the people I work with can't leave their homes. So it's like I'm walking. Andrew's like, "Yep, I can see it because I can feel you over there." So walking into people's homes and literally seeing empty fridges and them going, "Well, there's nobody available to get my groceries. There's nobody that has a vehicle this week or that's able to do that because they have their own health situation that's going on." For weeks, I've said if people would just help us, we'd be able to help more people. So I definitely, that's a big issue for sure.
Yeah. I think also, sorry, I'll just jump in for a second. I think in terms of social determinants of health, I'm also seeing like schools being closed is a hugely intense social determinants of health issue for our young people in our community that rely on schools for food and for counseling and for a safe place to go and for all of those things, and so that is I'm always thinking about that as well, how many health outcomes we're going to have with our youth because of school being closed, which are really worth preparing for. But Andrew, you were going to jump in.
Yeah, just like reflecting on some of the comments around communication and collaboration and community in a couple of different ways. So things have improved for me a little bit in my home care situation. And a big part of that was once I started to talk about it more publicly and with other people experiencing it, but also, more generally and bring attention to it. Things shifted internally with how my home care was set up. I'm with a different agency now. And one of the biggest changes is with communication, like just being able to talk regularly with them, know what my plan is ahead of time. Like I get my schedule in advance. And if there's going to be a cancellation, I know in advance and I'm able to plan a little bit. And before, I didn't know until the exact time. I'd be waiting until noon when they're supposed to come. And I get a call at noon saying there's no one coming. Right. And that's impossible. You can't plan with a backup plan when you have absolutely no notice. And now I feel like there's a level of communication there that can actually make it function. And in some ways it's like, okay, well, if there's, daycares are still closed, right? There's still a lot of limitations on staffing. So sometimes there just literally isn't anyone. But like if there's someone for 5 minutes to come and do this one thing, I won't need to go to Emerge, right? And like where I am now, we're able to do some of that, to come up with a middle plan, whereas before it was I just wouldn't get anything. And the piece about like being able to talk with people in community about it is not just feeling less alone in that, but there's actually been shifts. And that only came, like I was doing self-advocacy for years on this, right? Like I've been working with all the different people in the system and trying to approach it as best as I can to push for that change. And it wasn't until there was a whole community behind pushing that it shifted, right? So like that was significant. Yeah, so the other, like right now, I also, not that this is also a challenging thing where some of the care that I get now is from strangers. It might be delivering groceries, something like that, but talking about it more publicly, there have been some people who've reached out to be able to provide that because they wanted to and they could, and so they have. So that, like, I still think the system of home care is, in some ways, for some things, is the best because we need to have training for some stuff. There needs to be proper use of PPE. Not to say that necessarily have always gotten it in the system either, because there's been lack of support, like lack of PPE given to organizations. And now that there's more of that, it's in a better situation, at least from my experience. But like when it's strangers having to come in to help people out with things, they don't always have that training and they don't always know what's going on and what's going to be the best way to help transfer someone from bed to chair and that kind of thing. So it still is important for us to distribute and communicate within the system and not rely totally on community care for these things. But it does need to be more of a balance, I think. We need community connections. Maybe it's 6, maybe it's something different. And I definitely think that animals and other things like that are great connections too. But we need more connection. We need more of that because that's changed my situation significantly.
Thank you, Andrew. I think that brings me to a perfect point to switch to our last question that I want to explore with you all, which is around dreaming. I think this is an opportunity as we're seeing sort of a lot of things are frozen or stopped or different, and then we're going to be returning to some form of normal, but normal could change. And so what do we dream of or hope for in terms of change? And so if there's anything that comes to mind for you in particular that you feel like if we had that in place, it would have made a really big difference. Maybe we can put it in place now. This might be a moment. The thing that comes to mind for me, actually, I was thinking about this a lot after I talked to Brandis, just thinking about more mental health services for people who are home for whatever reason, whether it be old age or disability or other reasons that people are not able to access community. Things like the excellent pause drop-in mental health clinic is excellent if you can get there, but where are the community mental health nurses that can come check on you on a regular basis, or those kind of systems of care that we don't have right now as another level in the system? That would help my practice a lot. That would help the people that I support if there was more of that sense of just another person checking on you in terms of your mental health and providing some support. Does anyone else have one?
That would be absolutely huge. I just want to say I'm with you on that one. It's been, when you go into people's homes and they're just sitting there in tears, saying what's going to happen with my life and that type of thing right now. Not only are we trying to do the best we can, but we are not mental health professionals. That is not what we are trained in. So having to, do that on top of it. So something like that long-term would be an amazing addition to community support.
Yeah, and that is something that Halifax Connections and Dartmouth Connections, it is in their mandate. They try to follow an assertive community treatment plan where they do community work and meet people in their homes, because there's a lot you can get by seeing someone in where they live. It's just, I wish there were more models like that, because I do think there is huge, I think COVID is highlighting what we do need as humans. I mean, that social connections, yeah, we can connect over the phone, but we're really missing that nonverbal, that ability to connect, and we're missing so much in those. So I think more outreach after this would be great. Another thing I think that would have been great, or would have helped everything, is if we followed more of a housing first model. I mean, it's great to follow social isolation and quarantining if you have a place to live, and that's just not the case for a lot of our individuals living in Nova Scotia or around the world. So following a housing first model would give people space to isolate. And I know that's kind of a big a big dream to think if we could house everyone in Halifax, but I mean, other cities have followed that approach and have been successful in that. And second to that, I kind of mentioned this earlier, but I think universal design in our shelters would be a great step forward to allow more inclusion for our homeless population.
Yeah, thank you, Erin.
Thanks.
And I just got a comment that I wanted to jump in with that came from one of our listeners, and that is April Hubbard. The excellent and amazing April Hubbard jumps in to remind us that we really need to hear the voices of those people with disabilities in these processes first, rather than us trying to come up with solutions from the point of view of being the people who have some power and are care providers. And I think kind of that what I've been hearing from people in the community living with disability, telling me what they wish they had, has been really powerful. And I would love if our healthcare had more advocates and more people built into the processes where we're redesigning these systems with really hearing the voices of the people who are experts on what is needed, because it's their needs, as opposed to people guessing and hoping that we can improve systems based on what we have observed, but only secondhand. So I really appreciate that comment from April. And yeah,
that was actually the first thing I had written down on my list was my big dream would be for plans to genuinely include people with disabilities in the development of all of these things. That was my that's great. Like, and I think that's what I had written down around a crisis plan for home cares would be a specific thing, because in the same way as we send staff to Northwood in the crisis, we need to be doing that too with home care. So like tracking when people are getting cancellations, to require that we're tracking that somehow so that we can address it when it is a crisis level, and to make sure that there's actually the people who are receiving home care are involved in developing that. Like that has to be core to the system. Like, I don't think our system was designed with the people involved. So that would be a huge shift and a great one. And the housing we're talking about was really wonderful to hear that that's like a focus, because that has also been one of my points, not just personally, but with Tetra, is thinking about accessible housing, and the lack of it here is huge. And often the projects and the types of things, regardless if they're here specifically or not, are because of just this lack of accessibility in our design. And right now, everyone is isolated at whether it is a home here. It's like your one place that you're trying to figure out how to live in. And if those things were all accessible, whether it's a shelter or otherwise, like that would be a huge shift. That would be a huge and incredible shift that would mean people would be able to live much more independently and in a way that like just acknowledges that we are valued human beings, like acknowledged in the space around us. Wouldn't that be incredible?
Yeah, it would be incredible. And I think it's possible. I think it's really doable. Like we've seen other cities make housing first strategies work. We could have inclusive housing first be a big part of our budget. We could find a way to do it. Like Dr. Patriquin said, there's a lot of money in the system. It just might not be where it would most benefit people with disabilities.
Mm-hmm. And I think on that note, again, having mentioned lived experience and how important that is to be valued as much as other, data points or other things, how much certain services are being, utilized. It is really important to look at that. And I guess I would think, though, in general, we do just really have to think about people who are on the fringe, on the outside, people who are really kind of invisible. Like, people often become part of the conversation when they're super educated and literate and able to advocate that way. But just, we all have to advocate. And for the people that we're serving we know they just don't have voice or the language for it or the capability. And that's where we really have to come together and collaborate and create that community together, like work all together. And that sort of expression, like nothing for us without us. Yeah.
Nothing about us without us. Yeah,
exactly. That should really, really stick with us for all of this. And I guess, knowing that there are other inequities in our system, right? And certainly having a large Black population in my practice, who I feel very indebted to, because it's why I stayed in family practice so long, despite all the barriers, is just looking at people having other barriers to accessing good quality healthcare, and just addressing all of those in the midst of this, coming out of this crisis, knowing that also there is those other waves, right? Just as you said, we've got a lull now, we're going to come out of this, but we also haven't reached the larger wave of it. So what we can do now is really important, particularly because we can absorb more and learn more from each other now and put things into place for when it does hit in the fall or when something else hits us as being big. So now just sort of networking and collaborating, communicating more so we know what's out there and just sharing our resources and connecting to other people will put us in a better position for when it hits again.
Yeah.
And a better position for sustainable care where we don't have a lot of people in the system burning out who we really need to be resourceful.
Yes.
If I can just add to that, my dream big. I loved this question. I was like,
I have 3 sheets. I'm like,
right? Dream big. For me, I think a lot of it comes down. We obviously have huge staffing issues right now in any nursing field kind of stuff, and the majority, I don't want to get off topic too much, but the majority they do say is women. And I think we're struggling with childcare too right now. So, a universal childcare program, think big, right? Being prepared and having a backup plan for long-term care or home care support next time. Like we really didn't know where we were going to get staff to help out. So having that kind of ready, set aside staff ready to go to move into areas that are really, really struggling right now in healthcare industry would be amazing too. And maybe a huge hotel's worth of PPE next go, right? Just waiting for us, waiting to be cracked open. That would be great too.
Yeah, the PPE vault of our future is going to be amazing.
Yeah.
Also, I know I was definitely hearing in places like New York City that they had healthcare providers, daycares, and schools open for their children so that people could keep working. And that, I don't know, maybe there's something like that here, but I haven't heard anything. So wouldn't it be amazing to have some kind of very safe, really well organized care for the people that have to go to work? We don't want to have them pulled out of the system because they're home with their young children when their young children could be well and safely cared for.
Yes.
So
And in some of those places, home care workers are not considered part of those workers that are eligible for those places too.
Yeah, that's true too. In British Columbia, they did have that, but here they don't. Although we're essential workers, they don't have any childcare for healthcare people. So, yeah.
Well, and I think you mentioned it, Mara, and I certainly do a lot to sort of what I consider like humanize the healthcare system. But certainly one area of focus for me has been just, and even predating COVID, is looking at the really alarming rates of mental health issues and burnout in healthcare workers. And that's our largest healthcare crisis. And so even going into this, I made sure everybody asked, I polled like, how many hours a day are you working? So I'm going to tell you right now, you'd be surprised to find someone working less than 12 to 16 hours a day. Right. So I think we have to focus a lot on, humanizing our system for people using it, but also everybody, involved in it in that way, and accounting for just having healthier constructs around how we envision and live a healthy life, because we're all patients sometime, but, and looking at our system. I think education is a huge part of this. Like if we start building skills, capacity, kids right now could serve with learning a lot about emotional health. Instead, we're still getting math homework sent home. I'm in grade 2 math right now. But it's such a missed opportunity. Like, what do we value here? Like, who cares if the whole world is behind a year? Or even, my admin who's in nursing school, she's trying to get her training online, and they're putting up the rates 3%, like her tuition. How come we can't just train nursing aides, train, health professionals, and provide, less barriers to them even accessing education so we can serve each other? So it's a really different way of conceptualizing how we're going to care for each other and train people and build the capacity within our system as a whole. But it requires being informed at every possible level, right? And then working together. So there isn't that. Yeah.
And I think too, we have a responsibility to, since a lot of us work in the margins, try to work to give people the tools to advocate for themselves, because it's not on us to advocate one way or another, like April said, but rather maybe support people in advocating for themselves and supporting them and connecting to these resources, which we as healthcare providers or individuals who know the system through lived experience might already know how to navigate, which could be quite inaccessible to people who are new to the system or are facing barriers that prevent them from the system. So I think, just working at every level and making sure that we are working for, the client and the people and for the actual needs versus the assumed needs.
Yeah,
Absolutely.
Well, thank you all. This has been really inspiring and really heartbreaking too, because that's the kind of moment that we're in. There's nothing that doesn't have a big dose of heartbreak in it. Just in terms of the, severity of what people are experiencing, and all of us, I think our hearts are really open to that experience of the clients and patients and people in our community all around us that are alone and struggling and not getting the care that they need. But just to hear people's aspirations and the effort that they're putting in, it is also helping to warm my heart today. So thank you for sharing that. And we're going to wrap it up because it has been an hour, and so we will leave it at this. But anybody who wants to tune in this week, we're going to have a bunch of other conversations with a bunch of other people, and so you can check out reachability.org and come to our other workshops and bring your questions, and we would love to hear your voices. So thank you to my panelists, and thank you to everyone out there who's been listening.
Thank you, everyone.
Thank you so much.
Stay safe.
Bye, everybody.
Bye, guys.